Welcome everyone. My name's Dr. Melissa Lovell. I'm the convener and a research fellow at the Freilich Project for the Study of Bigotry at the Australian National University. It's wonderful to have you all here for our 2020 version of the Alice Tay Lecture in Law and Human Rights. I'm about to introduce Professor Sarah Joseph, who's our lecturer for this afternoon. She'll be presenting on the topic of human rights and COVID-19. But before I do that, I'd just like to acknowledge that we're producing this webinar on Aboriginal country, so land that's never been ceded. Obviously, Will, who's the head of the Freilich Project's board, and you can see him there, and I are both in Canberra at the ANU campus, and Sarah is up in Brisbane at the Griffith University campus. So welcome to you all, and welcome Sarah. Thank you so much for joining us and being prepared to present this slightly unusual version of the Alice Tay Lecture, seeing as we've gone online for this year. So Sarah Joseph is formerly the director of the Castan Centre for Human Rights Law at Monash University from 2005 to 2019. But now, as I mentioned, she's Professor of Human Rights Law at Griffith University, Brisbane. Our format today is Sarah will be giving a lecture of about 40 to 45 minutes, and there will be some time at the end for questions. So I'll hand things over to you, Sarah.
Okay, thank you very much, Melissa, and thank you very much to the Freilich Project for asking me to deliver this lecture. And I should say that Alice Tay actually taught me jurisprudence at the University of Sydney well, a while ago now, and so it's a great honour for me to deliver the lecture today in her name. So I might just move to share a PowerPoint, which hopefully people can now see. Moving on to my topic of human rights and the pandemic COVID-19. COVID-19 has caused a public health emergency, an economic emergency, and also a human rights emergency. I think COVID-19 has detrimentally affected probably every recognised human right across the world in all segments of society, though of course it has hit some people far worse than others. I wanted to start off with a brief reminder of where we have been, a timeline of COVID-19. When I was preparing this, it was weird how some of this just seems so long ago. I guess all of us are finding that 2020 feels a lot more than 10 months. Now, as far as we know, COVID-19 emerged in Wuhan in Hubei province in China in early December. I've got a question mark there because there have been some reports indicating that maybe there were some cases around a little bit earlier than that. China notified the World Health Organization on the last day of 2019 of a sort of novel cause or a number of unexplained pneumonia cases. So if you like, the word got out then. COVID-19 then spread beyond China, initially to some of its neighbours such as South Korea and also Iran. And then I guess the full scale and the extreme danger of COVID-19 became very obvious with you know, Italy's rather small coastline, which had sort of been, you know, prominent in February, suddenly escalating exponentially and alarmingly. And I guess, well, Italy's fate was worse than that in South Korea, but it was also, if you like, more prominent, more transparent than what was going on in Iran and China. And then Italy, we then saw equal devastation in some other European countries such as France, Spain and the UK. And the epicenter moved from China, the epicenter of this pandemic moved from China to Europe, but then on to North America, South America, back to Asia. And we all became very, very familiar with these logarithmic graphs. I mean, you can see one on the right, which is tracking the EU and the United States. And so we're now, I mean, this is going beyond Australia, but in the world, it seems like we're in the throes of very serious second or even third wave of infection and death. Though in some countries, it seems to have sort of almost been one long wave. United States, which can be quite misleading because the United States is a huge country, so it might just be sort of a wave, rolling across the country if we're going to use that wave analogy. But also in a country that we don't hear a lot about it in Australia is Iran. Iran's had a devastating impact from COVID-19, and it seems to have been one gigantic and rather devastating wave. Now on my timeline there, we look briefly into the future, a future where COVID-19 comes under some sort of control with effective treatments and, of course, the vaccine that everybody is waiting for. So turning then to human rights. And I want to start off by saying that in Australia, it's possible that human rights has become, has been a little bit discredited in this crisis. And if that's the case, I'm hoping it's not the case, but if it is, I think part of that is because some of the most prominent uses of human rights language have not been compelling and have actually been, somewhat embarrassing. And the classic example, I apologise for the fuzziness of this slide. This is, footage from a phone camera. The classic example is this woman. She came to be known as Bunnings Karen. Apologies to everyone called Karen out there. A lady who, I think it was around the time that masks were made mandatory in Melbourne, she went to Bunnings. She harassed these poor people who were simply just doing their job in Bunnings, quoting what she called the Charter of Human Rights from 1948, railing against compulsory masks. And I think she actually quoted, quote, the right to do what she wants. To be clear, that's not a human right. And a lot of the explicit human rights arguments have been based, like I think in Australia, certainly in America and parts of Europe, have been based on a wild libertarianism that just doesn't equate with a true human rights perspective. Human rights are not just about your own freedom and your own rights, but also the rights and freedoms of others, which is obviously very important with COVID. It's not all about, saving yourself from infection, but also making sure that you don't infect others. So there's always a need to balance your own rights and the rights of others. So let's turn now to look at some real human rights issues, not just the concerns of Bunnings Karen. So I'm going to refer generally to some UN human rights treaties. These are the treaties which bind Australia, and they also have global relevance. Australia is not a party to any relevant regional system such as the European Convention. So even so, a lot of this would exist in the regional systems anyway. Now, countries like Australia absolutely have human rights obligations to combat and to minimise and ideally to prevent pandemics. Now, such a duty exists under Article 6 of the International Covenant on Civil and Political Rights, which is known as the ICCPR. Article 6 protects the right to life. And there's a more detailed and explicit obligation in the International Covenant on Economic, Social and Cultural Rights, which is the ICESCR. Article 12.2c demands that states prevent, control and treat epidemic diseases such as COVID-19. But of course, you'll see later on, and you would be aware that some of the measures taken to combat the pandemic, certainly in Australia, but in most other countries, also engage countervailing rights, which I will come to. But in talking about human rights and COVID-19, I want to kind of return to this idea of the timeline. So I want to kind of start at the beginning being in China. Now, in terms of combating the pandemic, I think in retrospect, China, at least according to its own figures, has handled the virus reasonably well. It has emerged from a very severe lockdown earlier in the year, and it has managed outbreaks since. But that's not really what I want to talk about. I want to talk about, questions I think have to be raised about its level of transparency about COVID-19 in those very early days. It took China around a month to warn the World Health Organization of this strange pneumonia. And generally, the Chinese political system is just not one which encourages people to share bad news. It's also a system where the government is fairly insistent on appearing to be in control. So all of that is not conducive to openness and transparency about very bad news. That is a wildly infectious, deadly novel virus. There have, for example, been reports that there were a crucial 6 days in January in which there was knowledge of person-to-person transmission, but that was not openly, publicised either inside China and certainly not outside China. Now, a number of countries, most prominently the United States, have accused China of failing to share information at that early stage in a way that would have properly warned other states, and we will never know, but may have nipped this in the bud in the beginning. It's hard to say. The United Nations Committee on Economic, Social and Cultural Rights has issued a statement about COVID. It's issued a general comment on the right to health. And in that comment, it said that countries, states have duties to be obviously transparent to their own populations, but also to other countries in order to address a health scare and a pandemic, because a pandemic does not respect boundaries. On this issue of transparency, quite famously, it's known that an ophthalmologist whistleblower wrote social media posts in late December about a SARS-like disease, and only to be spoken to by Chinese security services. I don't think he was actually detained, but he was kind of effectively told to shut up. Now that man was Dr. Wen Liang, and he's represented in the first picture there. He became a cause celeb in early February when he was one of the early casualties or fatalities from the virus. The right to health, in conjunction with obligations regarding free speech, such as Article 19 of the ICCPR, require the swift publication of accurate information relating to the pandemic. Now, the opposite end of, the opposite of too little information is too much information. And we have had an issue with that too with COVID-19 in the form of too much disinformation. Now, that has been an issue all over the world. Maybe worst of all in the United States. And there is a tension in human rights as to what countries and governments are supposed to do about that, because suppressing misinformation is censorship, which is problematic. It also might, in fact, feed conspiracy theories rather than help suppress them. But regardless of all that, I think it's especially problematic if you have the head of a government as one of the main spreaders of misinformation, which appears to be the case with US President Donald Trump, who variously has promoted the idea that COVID-19 is just the flu, that masks are dangerous, and he's also promoted miracle cures. And even today, he continues to downplay its seriousness, even though 230,000 Americans officially have died from COVID-19. Now, moving on from the beginning of the pandemic to, I suppose, the middle of the pandemic, which we're still in. Now, countries have obligations to be prepared in the case of health emergencies. We can't say that COVID-19 itself was predictable, but obviously the nature of COVID-19 has become much clearer and much more predictable since at least mid-March. And so since that time, countries, especially those richer countries with actual capacity and much more capacity, they should have been doing things to prepare, such as acquiring appropriate personal protective gear for health workers, expanding intensive care beds, acquiring more ventilators, and so on. The Committee on Economic, Social and Cultural Rights, which I mentioned before, it's the body which actually monitors the International Covenant on Economic, Social and Cultural Rights. It's issued a statement on COVID-19, and it's commented that, that many countries were in a very poor position to deal with COVID-19 because of years of austerity policies, years since the last great financial crisis in the late 2000s. And while I said before that COVID-19 itself was not predictable, a pandemic itself probably was. And, you know, we forget in the midst of this, you know, extreme crisis that there have been, you know, recent pandemics and recent novel viruses such as AIDS, such as SARS, such as MERS, such as the resurgence of Ebola after a period of time, such as swine flu, and so on. And so, you know, while you could anticipate that, you know, you could say that, you know, it's unfair to expect countries to be prepared for a novel virus, it doesn't excuse every instance of bad preparation. And so, for example, it has been suggested inside the UK government has been heavily criticised for a lot of things, including a failure to stockpile appropriate protective gear for healthcare workers. And it's been suggested that that's actually been a breach, that represents a breach of the right to life by the UK government. Now, having said that, no country has unlimited healthcare. And you can look at, for example, northern Italy, where now that probably is one of the wealthiest areas of Italy. It might well have the best healthcare in that country. And yet clearly it was overwhelmed in March and April, to the point where it was triaging and rationing healthcare and rationing access to intensive care beds and ventilators. And it was doing that on the basis of age. Okay, it was in fact saying, well, look, this bed will go to a younger person rather than an older person. Now, in response to that, the United Nations Special Rapporteurs, so that is a group of independent human rights experts who are appointed for a period of time by the United Nations, they issued a joint statement in April to condemn this practice as age discrimination. But that's not to say that rationing of health resources is forbidden. And it actually happens a lot. For example, it happens with organ donation or access to organ donation. Now, I think when it comes to the need to ration, I mean, I mentioned before that states have obligations to be prepared, and some states were perhaps woefully unprepared for a variety of reasons. And it might be that there are, you know, human rights violations leading up to the need to ration healthcare. But, you know, at the point where you have to ration it, decisions, you know, have to be made then and there. Probably one of the most relevant cases about this issue of rationing healthcare is a case from the 1990s from South Africa, a case called the Subramani case. Mr. Subramani, his claim was about lack of access to kidney dialysis in South Africa, kidney dialysis for free, so on the, you know, provided by public hospitals. Because the relevant South African province was in fact rationing kidney dialysis at that point in time. And it was prioritising people with acute kidney conditions over people with chronic kidney conditions, because people with acute kidney conditions were more likely to recover and therefore, you know, only need dialysis for a certain period of time as opposed to those with chronic conditions. The South African Constitutional Court ultimately, I mean, you know, in what has been criticised as a fairly conservative decision, perhaps, did find that that decision was rational and was in accordance with the South African Bill of Rights. So therefore, according to that case, it was permissible to ration healthcare according to perceptions of whether someone is more likely to survive than another person. So it's probably fair to say that the UN Special Rapporteurs are correct. You shouldn't just use a crude measure of age, but you probably can use a measure of, you know, who is more likely to survive. And unfortunately, you know, all of, you know, the evidence from, I think, pretty much everywhere is that the most prejudicial trait for COVID-19 in terms of whether one is likely to survive is in fact old age. Before I move on, I might just say something about the images on the slide. That's an image, I think, from around April. They are nurses from Denver who they were stopping traffic. This was traffic on their way to an anti-lockdown protest. And so that was their protest against the protest, which I like the energy in this picture, or those pictures. Okay, now one of the ways, and certainly in Australia this has been the case, one of the ways that governments have sought to control and manage the pandemic and manage it so, for example, to flatten the curve and make sure that the hospital system can survive, and therefore, you don't need to ration healthcare and beds and so on, has been to adopt lockdown measures to keep people at home and therefore stop people from getting infected and therefore spreading the virus. Lockdown measures, therefore, are a measure which you can say is designed to protect the right to life and right to health and fulfil that obligation to combat the pandemic. But clearly here we are dealing with many, many countervailing rights, a vast range of civil, political, economic, social and cultural rights are affected by lockdown. So just to name a few, a right to a livelihood, freedom of association, rights to education, freedom of religion, rights of families and children, and I could go on. And we've seen the debate rage here in Australia about the appropriateness of the very strict Melbourne lockdown, which is only sort of just starting to finish. But then we see, okay, so we know, the rights impacted by the Melbourne lockdown, but then we see what happens without a lockdown. In early August, Melbourne had over 700 cases in one day. At around the same time, the entire country of the UK had around 800 cases. So that was around the same time. And then you look at the respective numbers now. Melbourne, very, very low numbers, and the UK is getting thousands of cases a day and is probably heading back into lockdown. But having said that, there's options in between. Lockdown doesn't have to be as stringent as Melbourne, and it doesn't have to be, so lacking or as lenient as in the UK. So here is where we sort of move to talk about the balancing of rights. That is rights to life and health against those countervailing rights of association, livelihood and so on. And to be clear, those countervailing rights can, in some cases, for some people, include countervailing rights to life and rights to health. For example, it is likely that lockdown has exacerbated mental health issues for some people. Furthermore, the right to life and the right to health, they're not absolute rights, they're not unlimited. And in fact, every government routinely balances the interest in preserving life against other societal benefits. And this is in their calibration of numerous everyday policies, such as speed limits or laws which either permit or ban dangerous activities. And in working out this balance in the context of COVID, I have to confess a lot of sympathy for governments. I think it's a really, really wicked issue to have to deal with. And I think it's one where I would suggest they have a reasonable margin of discretion. Now, limits to human rights are often worked out according to the principle of proportionality, which is quite a complex principle. But it does, for example, involve balancing rights against each other, the right of one person against the right of another person or against society, as well as the relationship of means to ends. Now, I think one real big problem when it comes to proportionality and COVID, particularly in Australia, where numbers, except for a period of time in Melbourne, but otherwise the numbers here have generally been quite low. And so we've got here issues, where does risk fit into this whole proportionality, working out the proportionality of a measure? And I'll illustrate this by giving an example. Queensland's border is currently shut to New South Wales and Victoria. For many months, or for quite a few months, it was also shut to the ACT. And this was a period of time when I don't think the ACT had a single case. They had no single record of a positive case in the ACT. There was a fairly famous instance, it was famous because it became very politicised, the Prime Minister got involved and so on, of a girl who was allowed, she was permitted to come to Queensland. She was from Canberra. She came to Queensland for her father's funeral, but she was not permitted to attend the funeral or comfort her family. She had to go into 2 weeks of hotel quarantine. Now, that clearly interferes with her human rights. It interferes with her family rights, her freedom of movement, her freedom of association, and so on. Now, it interferes with her rights. The question is, does it actually breach those rights, or is it somehow a justified restriction on her rights? And I think part of the analysis here, this is where risk becomes really interesting for me. She was from Canberra. And so already it's incredibly unlikely that she had COVID. And I guess we now know she probably didn't have COVID. Now, so these were extraordinary measures taken in the face of what is already a tiny, tiny risk. Now, the chances that she would have COVID and then spread it, and then that spread result in, an uncontrolled, catastrophe in Queensland, well, the risk of that is even lower. It's infinitesimal. But the problem is that that tiny, tiny risk does still include the possibility of catastrophe. One case can set off calamity, and apparently this is what, in fact happened in Victoria. We've been told that, perhaps 90% of the cases in Victoria's so-called second wave can be linked to a singular instance of hotel quarantine, of the virus somehow getting out of hotel quarantine. And so, even though the risk is small, the danger is huge. And so in that respect, perhaps the restrictions on her were justified. Now, I think we're going to learn quite a lot fairly soon about how Australian courts think about, risk, dealing with risk in this way. And that's because there is a High Court case going to kick off, I think, in November. It's a challenge by Clive Palmer against the border closure in Western Australia. And the federal court has already dealt with some fact-finding with regard to that measure, okay? So there's already been some hearings, not deciding the case, but just deciding certain facts. And if you read what the federal court had to say, it's actually very sympathetic to a risk management, to an extreme precautionary principle approach, that even though the federal court concedes that, for example, the danger to Western Australia of someone coming from South Australia is very, very low, they still accept that this is reasonable because, or they seem to accept that it's reasonable because, of the risk of actual catastrophe if they get it wrong. So we'll see. That's what the federal court has seemingly decided. That doesn't decide the case. We'll have to see what the High Court has to say, probably early next year. Personally, reasonable people can differ on proportionality. That's part of the magic and part of the problem with proportionality. I'm not sure that policies can routinely be reliant on such tiny, tiny risks. If that is the case, then the borders in Australia are not opening until we have a vaccine, and I'm just not sure that's sustainable. Another example I want to talk about is the one referenced on the picture on the slide. And it's one that, to be fair, involved a much greater risk, not a tiny risk, but probably a genuine, if small, risk. Now, this is the instance of the sudden shutdown without notice of the 5 public housing towers in Melbourne in early July. Now, the worry there was that the authorities had detected that there was spread, or that there were a significant number of positive cases in those towers, and so they were worried that there had been extensive spread, especially because people living so close together. And I guess no notice was given because they were shut down immediately. No notice was given. People came home and the police were there, and then they couldn't leave. Now, I presume that the reason for this is they didn't want anybody to abscond. So the risk is that someone or more than one person might abscond, they might be COVID positive, and they might spread the virus. Now, in that instance, I think there was a much higher chance of catastrophe than in the example regarding Queensland. But the measure itself, this was home detention without notice on people who had done absolutely nothing wrong. And personally, I can't see that as being proportionate. I note that a recent cluster in Melbourne, just in the last week, it was the cluster, if you like, that delayed opening up by one day, that seemed to involve a public housing tower, and I note that those same extreme measures were not taken. No other population in Australia has been subjected to that level, that extreme, home detention without notice at any other point in the pandemic, and I think there was genuine cause to wonder whether discrimination played a role in that. I think assumptions were made about non-compliance with regard to public housing residents in a way that I doubt would have been made with regard to more affluent people. Now, to be fair about all of this, I should say that I think Australia has done a great job with COVID, particularly in terms of suppressing numbers. But I hope that we haven't become over-reliant on the blunt coercive methods of lockdown, closed borders, and so on. And that goes to my last dot point there, that systems really matter. And maybe the biggest factor in the spread in Melbourne, I mean, we know that there were systemic failures in hotel quarantine. And, you know, there's a lot of evidence that there was relatively poor contact tracing, perhaps compared to other states, and poor communication with communities. There was not much in place from either the state or the federal governments to protect aged care, or indeed other vulnerable settings such as abattoirs and hospitals. So you know, that's just to underline systems matter, system improvement matters, that, you know, it's not all just down to people locking down, it's down to governments doing what governments should do and what we can reasonably expect them to do. Before I move on from this slide, it's not referenced on the slide, but I want to mention one other border issue, and that is the restriction on Australians flying out. I can't personally see that as a proportionate restriction. There is a relevant human right, which is the right to leave one's own country, Article 12.2 of the ICCPR. Australia is fairly unique in adopting this measure. For example, New Zealand does not do this. It discourages people from going overseas, but you can fly out. And clearly, you don't pose any danger to Australia by leaving Australia. The issue, of course, is what happens when someone comes home, which moves me to the issue of quarantine. And of course, there is the issue that when you come back, at the moment, anyone flying into Australia most foreigners cannot come into Australia, and Australian citizens have to go into compulsory hotel quarantine, and now they have to pay for it. For a few months in the beginning of the year, they did not. Hotel quarantine was probably instrumental in stemming the first wave, but sadly instrumental in the second wave. Now, quarantine clearly raises human rights issues because it effectively amounts to detention. And I do wonder, I mean, I do think it is fair at the moment to be, you know, imposing some sort of quarantine on people coming from outside, coming from other countries. But I do wonder whether its current strictness, I doubt it's sustainable, and I do wonder if it can be relaxed. At least a little bit more. I mean, maybe offer the option of an ankle bracelet. Personally, I would prefer that at home rather than being stuck in a hotel room. Or even, you know, offer something like bail in the same amount as is currently now paid for hotel quarantine. I think it's interesting, we compulsorily quarantine people who are flying into Australia and in some instances coming from interstate. And I think the figures show that around 1%, probably a little bit less, but 1% of those people have been COVID positive. We quarantine those people, but we're not quarantining people who actually have COVID. So, and who we know are infectious. So I think, you know, it's interesting that we've resorted to trust in one instance and probably a more important situation. And I do wonder, you know, if we can trust more. We all know a lot more about COVID than when people were initially flying back to Australia in March and April. I personally don't think hotel quarantine for everybody is sustainable unless we get a vaccine extremely soon. And I note that Victoria, even Victoria is currently talking about allowing home quarantine in some situations. Now, other measures besides quarantine are mentioned on this slide. Testing. I think Australia generally has done very well with testing and has done very well with testing since the very beginning. And I'm quite aghast at how some, you know, rich countries have been really poor with testing. It appears, you know, the United States had a lost month in March, and the UK, there's still a lot of complaints about testing and the time it takes to get a result and so on. Contact tracing has clearly been very important, and it has been a feature of probably the most successful countries and jurisdictions, and I would put there, that would include New South Wales and to an extent Queensland, though Queensland hasn't had as many cases to deal with. Now, I've got a picture of the phone there, so I might say something about apps. Now, an app, look, the federal government app has, I think rightly so, been criticised. Even today, the New South Wales Health Minister was saying just wasn't as effective as we've been hoping. But to be fair, I don't know that these contact tracing apps have been very successful in any Western country. Maybe one of the most successful, or at least most downloaded, so most trusted, is one from Finland, which was released in September. And, you know, the actual app had kind of privacy considerations built into it. So there was already a lot of trust in the app. But having said that, you know, the cases in Finland, just like everywhere else in Europe, are now going up with a pretty steep curve. There have been some countries in Asia, and here I'm thinking of South Korea and Vietnam, and they've been much more aggressive in their quarantine and contact tracing approaches, and in a way which probably intrudes much more into the right to privacy, protected under Article 17 of the ICCPR, than, you know, we are generally comfortable with in Western countries. The payoff for South Korea and Vietnam has maybe been more normal life inside those countries. So I do wonder, it's a discussion to be had. If a country is faced with drastic measures like lockdown or high COVID rates, and we know the problems with both of those, or a greater loss of privacy, it might be a discussion to be had. To be clear, I don't think we're in that situation in Australia, and I hope we never are. But, you know, maybe it's a discussion to be had in the United States, so good luck with that, or Europe, and again, good luck with that. But they do have skyrocketing cases. But having said that, we've got to be careful not to underestimate the importance of privacy. And I'm not hopeful that if a government was, you know, given sort of greater access to people's data and information about people, I'm not confident that they would easily give it up. I would refer to government's response to another emergency, terrorism, which indicates that governments don't readily give up new powers very easily. And if they authorise greater incursions into rights, governments the trajectory tends at the moment to be one way. Look, I don't have much to say about masks. I don't believe that wearing a mask is much of an incursion. I think it's probably proportionate, continues to be proportionate in Melbourne. I would say it would be disproportionate if masks were somehow made compulsory in Queensland. I'm not aware that there's any great discussion of that. You know, there might be areas of Queensland, say a hospital or aged care setting, where it might be quite reasonable. But I think generally speaking, you know, Melbourne's had a worse outbreak, and it's probably not necessary, you know, in a place like Queensland. Okay, I should acknowledge so far that I've really focused on issues of relevance to the general population, and there are myriad human rights issues which affect more vulnerable groups, of which there are many vulnerable groups. I only referenced 3 on this slide: elderly persons, including people in aged care, prisoners, so, you know, people in closed environments, you know, if there should be an outbreak. I think there's only been 1 outbreak in a prison in Australia, but this is a terrible problem in America at the moment. And then victims of family violence and domestic violence who can be in the awful situation of being locked down with their abuser. I'm not going to go into these issues. I can raise them, or they can be raised in questions, but I want to acknowledge that I have been focusing on more general issues rather than specific issues. The final slide, and for me, from a research point of view, maybe, you know, in some ways the most interesting is I mean, they're all interesting, but I think these are the ones, these are the ones that are coming, and they're kind of issues which I'm not sure, you know, we will know how to deal with. And that is human rights issues associated with a vaccine. I'm an optimist. I do believe, doesn't really matter what I think, but I actually do think that there will be a vaccine available in Australia in 2021. And clearly the whole world seems to be desperate for a vaccine. I do wonder if it's the most anticipated medicine, you know, ever. But, you know, we all want a vaccine, or most of us seem to want a vaccine so much that I think there are legitimate concerns about adherence to safety protocols, and whether manufacturers and governments might be tempted to cut corners, which would, you know, prejudice safety, prejudice right to health, and maybe even the right to life. A few months ago, Russia seemed to brazenly announce that it had publicly approved a vaccine, and it was criticised for that because no one seemed to believe that their vaccine had been properly tested, or even if it worked. I have to say, I think that in the end that story was overblown. I don't think there's great evidence that Russia is carrying out mass vaccination. It seems to be in the same area, you know, the same sort of stage 3, I think it's called, as, you know, other vaccines that we know a lot more about. I think at least with Russia, and probably China too, questions can be raised over the consent of those upon whom its safety is being tested. The Russian vaccine has been given to members of its military, and I do wonder, you know, to what extent were they able to refuse. Vaccines must be tested, like any medicine, upon willing subjects who have given informed consent. But it is also clear that, again, we have a US president who seemed very willing to pervert local processes in order to get a vaccine in time for the election. Now, that hasn't happened. It won't happen. The election is next week. Had it happened, that would have been an extraordinary breach of human rights in the United States. And I do think his efforts have probably undermined faith in the efficacy of whatever vaccine might come out. Now, let's assume that we get a vaccine and we assume that it's safe. Can it be mandatory? Can a government make it mandatory for people to have this vaccine? And I was surprised when I looked that there's not a lot of sort of international case law on this. There is a case which is churning through the European Court of Human Rights at the moment, a case against the Czech Republic, which frankly is really quite well timed. The relevant human rights issues for the person who wants to refuse a vaccine are clearly privacy, bodily autonomy, and also freedom of conscience. Now, vaccines rarely, I mean, I'm not sure there's any vaccine that has 100% effectiveness. And look, there are people who legitimately can't have them for health reasons. Now, where they can be key is in creating this thing called herd immunity. And that is a situation where most people are immune, so there's very little opportunity for the virus to actually spread. But that only works if there's reasonably high take-up of the vaccine. Now, the catch-22 is that if a vaccine is less effective, you actually need more take-up of the vaccine in order to reach herd immunity. And yet, if a vaccine is less effective, say closer to 70 and 60, it's probably more reasonable to conscientiously object to taking it. Any vaccine, it has, look, I'm obviously not an expert here, but it has been predicted that any COVID vaccine, if it comes out next year, that will be very fast, that it is likely, it's certainly likely to be safe, but it is likely maybe to be at the lower level of effectiveness rather than the higher level. If a government, so you know, we're kind of on virgin human rights territory there if a government should choose to make it mandatory. The Morrison government has indicated they won't. Now, if Australia does not make it mandatory, a question then arises as to whether certain private enterprises can demand vaccination for use of their facilities. And in particular, I'm thinking here about airplanes and airlines. And I think there's a really, really tricky question that's going to arise with universities. I think universities effectively would have to mirror what the government is doing. But I'm not sure campuses can get back to anything like normal until there is some form of herd immunity. And so in short, I think the debates that we're going to have about a mandatory or non-mandatory COVID vaccination are going to be fascinating, and they're also probably going to be fraught. The final issue is accessibility or availability of the vaccine. Who will get it first? There will be people prioritised, and that's, I think, perfectly reasonable. People like healthcare workers, aged care workers, and the most vulnerable, such as the elderly and people in aged care. I'm confident that a rich country like Australia will gain reasonable access to a vaccine. And then human rights obligations. Australia will have human rights obligations to make sure it's ultimately and fairly quickly rolled out to all corners, including the most remote. There is a bigger question, though, which is access to the vaccine in the broader developing world. In Australia, we have access even to extremely expensive drugs because of our public health system and our pharmaceutical benefit scheme. And this is not the case. This is the case in most developed countries, but not most developing countries, and certainly not the poorest countries. Compulsory trade rules, intellectual property rules can mean that a lot of essential medicines just simply stay out of reach of poor countries. I think that will and probably is already the case with some of the most effective COVID treatments, including the experimental treatments which President Trump had. So I think that could be a problem with treatments. Personally, I don't think it's going to be a problem with the vaccine. There's already in principle agreement by most countries to make it widely available. Though having said that, the United States is a notable absentee from that agreement. There is an Indian manufacturer which is quite famous, sorry, its name escapes me at the moment, but it's quite famous for kind of being the manufacturer of drugs for the poor, and it's promised to help make it available for billions of, millions and billions of people. And that's important because a lot of poor countries, they might get, the vaccine cheaply, but they lack the capacity to actually manufacture it. Now, I suspect any manufacturer, inventor, or whatever of the vaccine will provide it at a cut price. I think the public relations cost, and that might be naive, but I think the public relations cost of not doing so would simply be extraordinary. Big Pharma has developed a pretty bad reputation, and I think deservedly so. And I suspect this opportunity for redemption will be taken with regard to vaccine, not necessarily treatment. That completes what I want to say. I'm just going to finish by raising two technical issues, which I'm not going to do anything in detail, but just to show you sort of the extent of the human rights issues which COVID-19 raises. And they've come up in my talk. And the first is the issue of human rights in the private sector. For example, to what extent would a drug manufacturer have obligations to provide a vaccine for free or cheaply to a poor country? And, even the issue of an airline demanding that someone be actually vaccinated, to what extent do they have human rights obligations? And the second technical issue is the human rights obligations of a country like Australia to other countries. If we imagine, suppose Australia wins the race for the vaccine, and there is a promising candidate from the University of Queensland, to what extent does Australia have obligations to provide that to other countries, particularly poorer countries? Those are massive issues, which I'm not going to go into detail on, but I'll just say they are certainly engaged, just like so many other human rights issues, by the COVID-19 pandemic. So I'm going to stop there and hand it over for questions.
Thank you so much, Sarah. Melissa, did you want me to relay the questions to Sarah at this point? You're not, I can't hear you. We've got a couple to start off with, if you're ready, Sarah. Jana has asked, after thanking you for a fascinating talk, she's curious about what you think about Zoe Lee Butler's arrest. Was it proportional, she asks.
Okay, I don't know who Zoe Lee Butler is. I'm sorry.
I'm afraid I can't help you. I'm
sorry, I just don't know the instance.
If someone could explain. A Melbourne pregnant woman, says Janet.
Oh, okay. Yes, the lady who was, yeah, okay, look, I think that was a breach. Look, the whole issue of protest and COVID, look, I think the most interesting and clearest issue that brings up the arrest of the pregnant lady in Ballarat, I think. I mean, for a start, like it was, I mean, she was charged with a pretty, with the criminal offence of planning to undermine public health regulations. So they kind of overcharged her, if you like they used a charge which attracted like the longest sentence. I mean, I don't know what's happened to her since. But secondly, just the level of force used, and this applies to any law. You can have the most reasonable law, and yet the police can still breach rights in the way that they actually enforce it. I mean, this happens sadly regularly when it comes to enforcing almost any law, that you find that certain minorities get arrested a whole lot more than other people, than more privileged groups. So I think there was a real failure there in proportionality in the way it was enforced. And I think this is a more general issue which can come up with regard to protests. I think it's probably quite easy to not to have a lot of sympathy for people who, are railing against masks or lockdown, but, as I said, it brings up this spectre of selfishness and extreme libertarianism. It's not really human rights. But some of those protests I've seen, I mean, for a start, I think people, again, the enforcement, the very rigorous enforcement, which I've sort of seen pictures of, again, in Melbourne, and sometimes you see, well, there's more police there than there actually are protesters. I'm not sure that's actually proportionate. And again, you've got to be clever, or you've got to be smart about how you enforce it, because you can, extreme enforcement can have the opposite impact. It can attract a lot more sympathy and a lot more people who want to buy into whatever conspiracy theory.
Yeah, it's a good point. Now we've got people submitting questions in both the Q&A and in the chat. Might be best if we can to stick with the Q&A, but I'll get back to yours, Kate, anyway. But we'll start in order with Jack Lattimore, with Jack's question. What would you suggest is an acceptable risk level of COVID in people returning from overseas? And Jack says the rate in New South Wales is 2.3% since March.
Okay. I've read 1%, but that may well be all around Australia. And it does seem like the numbers in New South Wales seem to be going up, like there was 7 today, which is quite a lot. Look, I'm not qualified to answer that question. I mean, I'm not going to sit here and say, well, 1%. I mean, I just do think, okay, I can't sit here and say hotel quarantine itself is disproportionate, but I think, I don't think it's sustainable. I do think there are problems in the way that Australian citizens have been effectively refused entry to return home. And I'm not saying they shouldn't quarantine. I just think that, you know, there could be greater trust in people to actually stay at home. Now, on what criteria, I'm probably not qualified to come up with that, but I can say that Melbourne, Victoria is thinking about that. And we all know that there have actually been problems in hotel quarantine itself and not just in Victoria. And again, I refer to the fact that, okay, that's 2.3%. 100%, well, probably 99% of those actually diagnosed with COVID, that is, they've tested positive, have COVID, because there's the odd false positive. They're not quarantined. I mean, they are told to quarantine, but they're not shoved in a hotel and told to pay $3,000. They're trusted to stay at home. And so 2.3% is a whole lot less than 100%. So there just seems to be a bit of a disconnect in policy there. And I do think that we are going to have to start looking at alternatives. That could include a slightly shorter period of time. But look, I get it. That's also difficult. I mean, I can refer to countries in Europe which have a shorter quarantine, and it's perfectly acceptable to say, well, look at Europe now. But, you know, I don't know, there's a lot of evidence that spreads come from quarantine. I think the spreads come because there's been no restrictions for months.
Thanks, Sarah. One from Kate. Kate's here.
Hello, Kate.
Again, she thanks you very much for a comprehensive and fantastic talk. I wonder if you think that testing as opposed to vaccines could be made mandatory, or whether this would violate rights.
Oh, that's a hard one. Well, I mean, I actually don't know what I think about. I mean, this is a bit of a cop-out, but on the vaccine, I mean, I was surprised at this issue. I just could not find a human rights case on it. Having said that, mandatory vaccination is pretty rare. It's pretty rare. Like, there is mandatory vaccination, but then there are allowances for conscientious objection. And, you know, all you got to do is somehow prove that you conscientiously object to vaccination. I don't know how hard that is, but it actually allows the sort of exceptions which, you know, engage human rights. So that may well be why it hasn't come up so much. And I just don't know that this is an issue that we've confronted in this way before. I mean, we can say that anti-vax does, you know, I mean, there's been resurgences of measles and things like that, and I'm probably not qualified to know, but it does seem there's probably a link between that and the rise of anti-vax. So it's very difficult. I don't think it's clear cut that mandatory vaccination, obviously if someone's got a health condition, they cannot be made to mandatorily vaccinate. I think one real difficulty that could arise is if the vaccination is actually, you know, not that effective, 50 to 60%, as I said, the reasonableness in refusing it becomes much more compelling. Compulsory testing. I think that is much more acceptable when we move away from the swab on the nose, you know, getting the swab right up your nose, which, you know, I think for everybody is uncomfortable. I haven't had to experience it yet, so I don't know, but I can't imagine that. But I think there are other tests out there. There are already other tests out there, like spit tests and stuff. I don't think it could be mandatory tests for everybody in every situation. I think you'd need a pretty compelling reason. Now, there were some very worrying reports. I've been quite strident in saying, look, I think some of the reason why it happened in Melbourne was sort of system failures. There's no doubt that there was also sort of some, non-compliance and misbehaviour. And I was quite worried about a month ago, there were reports in the paper about people who were visiting GPs. The GPs were pretty clear that they thought they had COVID, that they were coughing and they had all the symptoms, and they just would not go and get a test. Now, in that situation, that starts to get proportionate, but I don't mind saying I find this really, really hard, and I think I'd rather hear all the arguments for and against. But if it involves simply spitting, onto a sheet of paper, that's a lot easier than getting a big swab up your nose.
Okay, Kate,
so
I think we might need to leave it there. We've got about less than a minute left, so I'd like to take the opportunity to thank you very much for your lecture. Unfortunately, we didn't get to some of those questions, but
oh, well, I'm on email.
Excellent. So if you've still got questions, email Kate or email us at Freilich Project, and we'll pass them along to Kate. So thank you, Kate. Thank you to everybody, and goodbye.
Okay, cheers.
Thanks, Sarah.
Thank you.